Thank you very much for this kind invitation and introduction. Dear colleagues, what do we know about drug dosing in the obese? Well, when it comes to our hypnotics, opioids, and neuromuscular blocking agents, we know that we shouldn't use total body weight. We use dosing scalars, ideal body weight, corrected body weight, lean body mass. But what about often life-saving drugs such as antibiotics, heparins, vasopressors? Now, before I go into detail, I need to disclose the fact that our department did receive some non-restricted educational grants. And when we move on to antibiotics, correct dosage of antibiotics in the obese is important both in treatment and in prophylaxis, because some of these antibiotics are not only toxic, but on top of that, we do know that obese are also more prone to infection, and specifically surgical site infections. And the mechanism behind it probably involves multiple mechanisms. It has to do with the fact that obese have the microcirculation and the inflow of oxygen into the tissue is lower. And this is important because in the neutrophiles, one of our main components of defense against bacteria, needs oxygen in the process of destroying those little critters. There are some studies claiming that post-operative, adding oxygen in the post-operative phase reduces surgical site infections. Well, recent publications were not able to show that. The problem of surgical site infections probably also has to do with the fact that we underdose our antibiotics in the obese. And of course, many of the obese have hyperglycemia, type 2 diabetes, and make these patients more prone. And there are also some very practical issues. For instance, the skin preparation, the method of skin closure plays an important role. And you know these types of morbidly obese patients, you need about 1 gallon of povidone iodine to disinfect. The skin is full of crevices, very difficult to disinfect in one clean swipe. Now, interestingly, there is a clear link between antibiotics and dosing of drugs. We all know the use of the introduction of ideal body weight. Well, it came from the insurance companies. The Metropolitan Life Insurance Company used the concept of ideal body weight. And very interestingly, it was Divine who used the concept of ideal body weight for drug dosing of the toxic antibiotic gentamicin. And it's very interesting to see that even in the pharmacotherapy of antibiotics, the introduction of ideal body weight saw also its use. This is, for instance, the Sanford Guide for Antimicrobial Therapy, and you will notice that ideal body weight, corrected body weight, is introduced for drugs such as aminoglycosides and vancomycin. Now, when it comes to the treatment of infectious diseases in the obese patients, I could go through the list of all the antibiotics, but for the sake of time, I'm not going to do that. And you will notice for some antibiotics, you can use total body weight. For others, it's lean body mass or corrected body weight. And to give you a good idea, these are, in my opinion, some great review articles. If you want to go into detail, I would refer to those two. Prophylaxis is maybe more important, and the antibiotic of choice for prophylaxis in the obese is cefazolin. And we should know some basics. It's a highly protein-bound antibiotic. The half-life is about 1.5 hours. It has a very small volume of distribution, indicating that it's highly hydrophilic. Only the unbound fraction is effective. And also, don't forget, it is a beta-lactam antibiotic, so that means the time of the unbound plasma concentration above the minimal inhibitory concentration is very important. And the minimal inhibitory concentration should be maintained for at least 60% of the dosing time interval. Most of the staphylococci and enterobacteria are sensitive and it's considered that minimal inhibitory concentrations around 2 milligrams per milliliter should be enough. Another important factor is the probability of target attainment, PTA, and it should, normally it's set at about 90%. Now when it comes to prophylactic administration of cefazolin, when you look back in the literature, in the 80s there was the use of fractionated dosing, 1 gram at, before surgery, 1 gram at induction, and this has evolved to a 2 gram dosage of cefazolin. There are some studies exploring the use of 3 grams in high BMI groups, but apparently it did not offer any extra protection against surgical site infections. 2 grams should be sufficient. And some recent publications advocate the use of 2 gram loading dose and a continuous infusion of 1 gram of cefazolin during the procedures. Now, as I mentioned, cefazolin is only effective in the unbound form. So when you look at publications on focusing on measuring on unbound cefazolin concentrations, you will notice that even after about 4 hours of surgery, the plasma concentrations are still above the minimal inhibitory concentration of 1 milligram per milliliter. Don't forget that in the obese, the higher cefazolin clearance has to do with the age and not with the total body weight. And as such, a 2 gram dose should be sufficient. Redosing should maybe be considered after 4 hours of surgery, although a recent publication by Chen clearly identified the fact that 2 gram, if you use high-pressure liquid chromatography from the fat tissue and the epigastric fat tissue, this study showed that even after 200 minutes, the concentration inside the tissue is still high enough. This is a publication using microdialysis, and what this publication showed that in the obese, if you compare them to the non-obese, the tissue concentration is lower in the morbidly obese patients. And this study even developed a 2-compartment model, defining 2 models. And using this model, the authors performed simulations up to 5,000 obese and 5,000 non-obese, and they were able to make a graph on the probability of target attainment, and you will notice that in the interstitial fluid, the concentration of cefazolin after 120, 180, and 240 minutes, you will notice that after about 3 hours of surgery, the concentration falls below this PTA of 90%. And for this reason, the authors advise after 4 hours of surgery, you should go for an extra dose. And if you're dealing with bacteria that have a higher minimal inhibitory concentration, you should have to go for a redosing after 2 hours. This is an example of, in our hospital, how we work. We start with 2 grams of cefazolin. High BMI, we do give 3 grams, and we repeat the 2 gram dose after 2 times the half-life of cefazolin, meaning after 3 hours. Another essential drug in morbidly obese patients is, of course, the use of heparins. And I will restrict myself to the dosing of low molecular weight heparins in the morbidly obese patients. Now, I have to give you a word of warning. Is there an ideal dosage scaler for low molecular weight heparin? Unfortunately, there is not. If you look, for instance, enoxaparin, total body weight, dalteparin, total body weight, whereas some publications advise to use lean body weight, tinzaparin, etc., you will notice many of these studies are inconclusive. And probably this has to do with the fact that the volume of distribution of these low molecular weight heparins corresponds to plasma volume, and we know that in the obese, as total body weight increases, your plasma volume will increase, but in a non-linear way. These drugs have a renal clearance, and for instance, in obese, they have increased glomerular filtration rate. Many of the studies advise to monitor your low molecular weight using anti-10A levels, but this practice is questionable. For instance, these are some older recommendations, and they state use a higher dosage, about 30% increase, use anti-10A monitoring in patients weighing more than 190 kilograms. But this anti-10A activity monitoring, there's something that I need to warn you about. It's the fact that it's no longer routinely advised to apply anti-10A levels. The anti-10A concentrations can also be easily predicted from the total body weight alone. And do not forget that the risk of thrombosis and hemorrhage are not predicted by these anti-10A levels. And on top of that, the technique used for determining anti-10A levels uses a technique called chromogenic assay, and the inter-assay variability, even among, for instance, enoxaparin, dalteparin, is very huge, making this not such an ideal technique. Do we have studies on low molecular weight heparins? We have loads of studies, and the drug that is studied the most is enoxaparin. But look at the recommendations, look at the dosages, look at the time interval advised, and you will agree with me, there's a huge heterogeneity in the drug dosing. This is a recent publication which from a Dutch group, and they used a fixed dose of enoxaparin, 40 milligrams subcutaneously twice daily. No major bleeding was reported in this study. There was clearly a negative correlation between anti-10A activity and total body weight. And based on the data, the authors were able to make a pharmacodynamic model, and they simulated their patients, and they divide them in 3 groups: a group less than 110, between 110 and 150, and more than 150. And you will notice that specifically in the group 110 and 150 kilograms, the best dosage was about 0.65 milligrams per kilogram in the group of 110 and 150 kilograms. And in this, using this dosage, about more than 90% of patients were within limits. Now, anesthesiologists are practical people, so we need some practical guidelines. And this is, for instance, a guideline published by the Hemostasis and Thrombosis Committee from the UK. In my opinion, a very practical dosing scheme involving multiple low molecular weight heparins. This is a recent guideline published by the European Society of Anesthesiology concerning dosing these drugs in the obese, and they clearly identify 2 risk factors, a group patient-related, and some of them are surgery-related. And you will notice, for instance, abdomenoplasty is an important surgical risk factor. You know, these patients, after they have lost weight, they have huge skin excess, and it's specifically this type of surgery is very prone to thromboembolism. So the European guidelines focus on low-risk, high-risk groups, and they advise to use, for instance, in the low group, anti-10A dosage 3,000 to 4,000 units. In high risk, a higher dosage with extended low molecular weight therapy going up to 10 to 15 days. For non-bariatric surgery, the guidelines are more shady. They only mention high BMI, thrombosis-prone surgery, and again, with a recommendation. And you will notice that in these guidelines, twice daily dosage is important. Now, even on these guidelines, a word of criticism, there are some publications that show that not only coagulation system is disturbed, but also the platelet function. And maybe we should also add aspirin, acetylic salicylic acid, in our medication after surgery. The European guidelines want you to convert international units to milligrams, and this is not always easy. For instance, did you notice that many of these pre-filled syringes, they don't have any marks on them? So if you want to administer, for instance, 35 milligrams of enoxaparin, it becomes very difficult. When it's concerning treatment of thromboembolism with low molecular weight heparin, until further notice, we should use total body weight, avoid once daily, use 1 milligram per kilogram total body weight every 12 hours. Capping is not necessary, except, for instance, for patients who have acute coronary syndrome. It is advised to cap the dose of the low molecular weight heparins. What about vasoactive drugs? Much to my surprise, the focus on vasoactive drugs is not so much on total body weight, ideal body weight, lean body mass, but on the issue, should we use weight-based dosing or non-weight-based dosing, meaning micrograms per kilogram per minute, or simply micrograms per minute. Now, is it important to know the dosage of our vasoactive drugs in the morbidly obese? Because after all, you titrate these drugs according to the effect that you want. But we know from studies that there is a very poor correlation between the dose you give and the plasma concentration, and on top of that, even the plasma concentration and the clinical effect is poorly correlated. But we do know that any administration of, for instance, norepinephrine above 1 microgram per kilogram per minute is highly associated with mortality. And I think it's also important to know the dosage in your decision making. For instance, for norepinephrine, if you have a dosage higher than 500 nanograms per kilogram per minute, it is advised in recent guidelines to start up vasopressin and to start corticoids. But take this example. The total body weight of this man is 200 kilograms. His lean body mass is 100. Imagine if it should be dosed on lean body mass. This patient is receiving, instead of 500, is receiving only 250 nanograms per kilogram per minute. So yes, I do think it's important to know the exact dosage, what we are giving to these patients. To illustrate, these are some publications in non-obese patients, and you will notice the amount of dopamine or dobutamine that we are giving results in huge differences in plasma concentrations. Now, weight-based dose, is it advisable to use weight-based dose in the obese? Amazingly, obese patients do require less vasopressor. Probably it has to do with the fact that they have an attenuated system involving interleukin-6 response. If you look at studies that have focused on weight-based dosage, they show that the obese need less norepinephrine, but when the dosage is expressed as microgram per minute, there's no difference. So maybe these publications indicate that weight-based dosing is probably not necessary. This is a study, a retrospective study on centers using non-weight-based treatment. And when they look at the primary outcome, the need for hemodynamic supports agents, secondary, to obtain the target of a MAP of 65, these publications, this study showed that fluid resuscitation in the obese received less fluids, more secondary agents. The time to reach hemodynamic stability was longer in the obese. In other words, non-weight-based treatment is maybe questionable. But when you look at, for instance, this publication, when it comes to outcome, higher 1-year mortality in the obese, it was the cumulative norepinephrine exposure that was important, the total norepinephrine exposure. But if you look at the fluids administered, the obese received not less fluids than non-obese. So the 30 milliliters per kilogram crystalloid that are necessary in the treatment of sepsis, maybe this 30 milliliters per kilogram should be based on ideal body weight, corrected body weight, in other words, ideal body weight with 40% excess body weight. This is a study that compared both, and when you look at the time to reach the target, it was the same in both groups, but the weight-based, those on weight-based dosage were longer on norepinephrine from reasons not clearly explained by the authors. Vasopressin in morbidly obese patients, instead of using fixed dose, we probably need to use adjusted body weight when we want to use vasopressin. And for a drug like dobutamine, probably we need to use total body weight. Now, to conclude, I hope, my dear colleagues, it is clear that the dosage recommendations and guidelines for dosing these drugs in the obese are not only difficult to find, but on top of that are difficult to make, and definitely further research is needed in this field. Roman, I give back the word to you.